Hello to this special podcast on hand longevity and menopause. Today we're joined by Dr. Pooja jaisal, our specialist in gynecology and obstetrics and one of the big shots in women health and women longevity. Thank you for being here.
Thank you for that kind introduction. I don't know about big shot, but of course, I do believe that menopausal therapy and longevity is the thing, and it should be the focus of women care in the future, not only in the future, in the present context. Every aspect of a woman's life is some way or the other related to the hormone therapy. So thank you for having me, and let's discuss some more about hand care in women.
You know, why are we sitting here, a hand surgeon and a gynecologist? Because when I look at my special consultation for the aging hand, I see 90% women and only 10% male. And these women are, most of them are a certain age. They are older than the end of the 40s or in the early 50s. And they have very similar symptoms. They complain about pain, although the x-ray is still normal. And that's why we came up and have a look what is the importance of the menopause on the hand health. And we found out that menopause is one of the main driver in hand aging.
That's very interesting. I'm really glad we are talking about this because as a gynecologist, I think our main focus is more on hot flushes and night sweats and mood disorders. And those are some of the recognized symptoms which women do recognize. They are aware, they come and talk about it. But I think hand is one thing which is not so much taken notice of until it is very painful or the symptoms get more aggravated, or sometimes it is that through referral the patient recognizes that they do need care in hand. So I feel there is an unmet need to educate and make our patients aware that now modern treatment is available, and there is a great need of care in the hand therapy. We need to collaborate and we need to understand the pathology behind the different symptoms that women encounter past 40, past their perimenopausal, or even in the menopausal age group.
Can you explain a little bit what is the reason for these symptoms, and is there a pre-menopause or menopause, or even the elderly women above 70, it's a special group, because then they have all the symptoms. If untreated, they have the full bouquet of symptoms and problems. So probably that would be a good way to start.
So just to give an idea, I think most women in today's world are aware that we have the female hormones. So most people are aware of estrogen and progesterone. But now, as more and more women are getting aware, there is also testosterone, there are androgens, and these are protective. They are inherently present in the human body. And as a woman ages, so through the 20s and through the 30s, they have the benefit of good quantities of estrogen, progesterone being created by their own ovaries. But as the age goes on, and sometimes in today's world, there can be pathologies like endometriosis, there can be other diseases which can adversely impact the ovarian health. These hormones, they tend to dwindle. On an average, the menopausal age group is around 50 to 55 years, but you can never predict. You know, women start encountering the symptoms even in their late 30s or early 40s, and we are doing a disservice if we are not providing with them the care that is needed. So basically what happens is that these hormones, they start depleting, and thanks to the estrogen, which gives you a cardioprotection, your muscle health, your bone health, the soft tissue,
Skin
the
health.
support. Yeah. So skin and hair and nails, especially. So when there is a loss of muscle, and then eventually, if it's not recognized, slowly there is the pathology goes on. The skin gets more thinner, the nails get more brittle, and the nerves, they start getting affected, and they come with, I think you would be getting patients with the hand symptoms. So what is it in your practice that you see?
Well, as you said, you have three big symptom groups. The one is the pain. That's why patients are coming. They have pain, although they have already normal looking hand, and even if you make an X-ray, you don't see joint changes of osteoarthritis. That's the early stage, but that is one of the major information to pass, is that this pain is very often due to the lack of estrogen and can be easily corrected by replacement of estrogen. The second group, as you said, is the visible changes. So the outer changes, which is the skin and the nail are in the hand, and the skin becomes thinner. The skin shows a couple of dark spots, which are called age spots, and you see the blood vessels and the tendon more pronounced through the skin.
That's very interesting. I'm really glad we're talking about this, you know. I think for women, I think the face and the hair and the skin is so very important. And they use a lot of products for, you know, the skin to look more supple, more, more shiny, the glow on your face. And somewhere down the line, you have to understand the pathology behind it. A simple thing like something which is deficient. You know, we are all okay with thyroid supplementation and, you know, biotin and other minerals and multivitamins and small trace elements which are responsible for the health. But I don't know why there is a shyness for, these essential hormones as well, which can be easily supplied. And they are available now that we have more guidelines which are there to guide us and also to allay the anxiety related to its usage.
That's a big point, because we were, even at medical school, when we were in medical school, we were taught that you should not replace hormones because of risk of breast cancer. But as the new guidelines clearly show, you should be cautioned in case of breast cancer, but breast cancer is not breast cancer, so there are a lot of different types of breast cancer, and it's only one type who is a little bit of risk. But even for those, there's a lot of discussion to do the hormone replacement and to increase the screening mode then. So it's no longer a myth, or it's a myth that you're not allowed to do hormone replacement in women because of breast cancer risk. That's another thing.
So that's I would like to add on that, recently we have revised the guidelines.
Yeah.
We follow the NICE guidelines and the British Menopausal Society and several other societies like the European guidelines, and they have revised, and it's latest in February, and then again in April. We have in 2026 that, they have taken away the black box warning, and they have said that, there are different ways, and of course, you need to reach out to the healthcare provider. They need to evaluate you. Certain complex conditions and your individual risks need to be assessed. And as long as the benefits are outweighing the risk, there is actually no limit as to, how much you can give. It, of course, is individualized, and it has to be under supervision. So like getting back to the hand component, I see that there is a lot of potential. We need to collaborate. We need to make sure that the woman is guided to the right, healthcare provider who can identify these needs, identify the lack of certain things, and kind of make it more holistic and more wholesome in their approach. So, for your practice, you expect women. What symptoms do you think they should come to you? Or is it necessary that they need to be referred? What are the symptoms which a woman thinks can bring her to a special healthcare provider, especially for a hand case?
Well, most of them, they have pain. Either they have pain, or they recognize that their rings do not fit anymore.
Oh, that's nice.
Because when the rings do not fit anymore, that's the start of the joint changes. Osteoarthritis starts with thickening of the soft tissues before you see any signs of radiological signs of osteoarthritis. So that is one thing. The other thing is that the skin and nails are changing. Skin becomes thin, nail becomes brittle. And the third thing is that they have symptoms, orthopedic symptoms. They have pain at the hand when they flex the finger, so its finger can click or even lock, what we call a trigger finger. That's the aging of the tendon.
So that also is related to the hormone deficiencies.
Yes.
Interesting.
Well, it's related to hand aging, but as hormone deficiencies is one of the major driver of this aging and accelerates the aging, that's why we should think about it. And the other main thing is that patients are coming and have tingling and numbness in the fingers, and wake up at night and have to shake the finger, which is the carpal tunnel syndrome, which is nothing else than the aging nerve.
That reminds me, I get a lot of patients with the similar symptoms, pregnancy related. So we have patients either prior to pregnancy and some patients after pregnancy, after delivery. They still complain of hand weakness. They complain of pain in the night. They complain of numbness. So, these are...
It's 30% of pregnant women. So that is good to know where to send. The good message is that this comes and goes.
Okay.
And there's only in very rare cases that we have to do something, but you can treat those conservatively. But the other big group in the young age group is after birth, when they give breastfeeding or when they take off the baby and they have the so-called mummy thumb, which is nothing else than an overuse of the tendon. Is the same in the older age group. It's an overuse, an inflammation of the tendon, which makes the movement painful.
I think, again, there are these hormones involved. So the progesterone and the estrogen. So progesterone component is involved. And you know that there are changes in the body post-pregnancy where the woman is undergoing changes. Again, similarly towards the perimenopause and the menopause, there are changes that are happening in the body. So progesterone also is responsible for a lot of calmness, muscle strength, maybe the muscles to be more resilient, more flexible. So I feel that getting them educated and aware, and maybe if the hormones can be given in a right manner, starting off with the lowest dose. So we individualize, we check what is necessary. In my practice, I feel that women can come in for 3 reasons. A, if they are having symptoms, okay, so have a symptom control. Mostly we see women coming with annoying symptoms of mood swings, sudden outbreaks, anxiety, brain fog. And most of these women are very, very, active, involved in there, and they were doing multitasking, and suddenly they feel that they can't do that. And that is when they want to seek help. Either they are going through a perimenopausal transition, or the next set of patients are the ones who are already into menopause, and they feel that they don't feel that energetic anymore. They have this lack of energy, tiredness. So these are very established symptoms of menopause. And the third possibly could be to protect the bone health, to protect the osteoporotic fractures. So osteoporotic fractures is nothing but your bone thinning, and then if it's not given the right support, you can have, with trivial trauma, with little trauma, you can land up with fractures. Like hand, I think Colles fracture, it's so common.
Second common fracture in the elderly, It's only topped by the spine fractures, but the wrist fracture is number 2, and the hip fracture is number 3. But as you said, the same patients are seen by different specialities for different symptoms. What we should do is to think about where can we help the patient is this symptom, which is not in your group, in the hand, is not part of gynecology, and gynecology is not part of hand surgery, but why shouldn't I think of a patient coming to me with aging hand symptoms and see this age group and ask the question, do you know about are you in menopause? Do you know about hormone replacement treatment? Would you like to have some information? Because I know it would help me very much. I could avoid pathologies and pain for the patient in the future, or at least I could reduce it, you know. And that is the fantastic thing. If you can cooperate with another specialty, you would not think
absolutely,
about.
absolutely. A multidisciplinary care is always more holistic. It caters to all the needs, and it makes sure that the woman gets the benefit of the expertise of each person from different specialities. So I believe that what you are promoting or what you are suggesting is the best in the interest of the woman. So they can lay down the foundation, they can make themselves aware, start off with the dose, and then they need to be reviewed. They need to be reviewed by their special expertise.
For these specific hormones, which is your job.
Yeah.
I mean, this is nothing you send to the family doctor or the general practitioner. That should be done by a specialist.
Yeah.
And that's why I think it's good to have this cooperation and to be followed up by the right one.
Absolutely. Absolutely.
There is one group I would like to ask you, what are you doing with women with contraception? Normally, if they have contraception, they have hidden symptoms. Or do they have the same symptoms in menopause if they still on contraception?
So contraception also is somewhat replenishing their hormones.
Hormonal contraception.
Yeah,
Okay.
yeah. So there are these hormonal contraceptions, but we want to let the patient know that when you have the beneficial effects available with lower doses, why would you want to go for higher contraception?
That is
Because the
yeah.
oral contraceptives,
High
A,
dose.
they are at a dose which is much higher than what is required for a hormonal replacement, and B, most of them are oral. So in modern menopausal therapy, you have non-oral modes of delivery. Like you have the estrogen in the form of gels and patches and even sprays. So the benefit of this is that the risks are minimized. Yeah. So when you're not giving through an oral route, A, the dose is much, much lower. B, you're bypassing the liver. You're bypassing, if at all you have any absorption related issues, like you're not able to absorb because of some GI issues, you have some tummy upset, you have gastrointestinal upset, you take a much lower dose. And also it does not interact with other medicines if you're taking, because if you take oral contraceptives, I think normal public needs to know this, that they are enzyme inducers. So they will make the efficacy of other drugs much less. So why not give the lowest possible dose? So instead of going for the oral contraceptives,
which is the reason that women are much more resistant to alcohol.
Yeah.
You have a better trained liver.
Absolutely. That's an advantage, I would say, on the long run. So having said that, when you have lower doses available, when you have better modes of delivery, when you have safer doses, and believe me, why are we a little reluctant to give oral contraceptives in women beyond 35, 40? Because then there are these lifestyle illnesses which come in, hyperlipidemia. They may have, high fat content. They may be, especially with high risk groups, like with high BMI. That is, you're obese.
Obese, the big ones.
Yeah, obese women in that age group of 40s, your age. If you are having some addictions like smoking, alcohol, these will increase your risk. Plus, if you have a family history, you are prone to more risks of these hormonal medications. Estrogen, especially, people are worried about thromboembolism, clots, to be, in simple language, we can say that they can cause clots and strokes. So if you can avoid the oral route and if you can give the minimal dose, the risk of these clots is minimized. It's very, very less because, directly it is going in your bloodstream. So that is one big advantage. And secondly, we start one hormone at a time. We need to give in the lowest possible dose, which will be responsible for symptom control. And the woman needs to be reviewed. So each time you start the dose or you change the dose, you need to call her back in 3 months, review her.
3 months.
Either, yeah.
6 weeks or 3 months?
Yeah.
3 months. Okay, but it's worth it to come back. And the good news is this is covered by insurance.
I'm not too sure about that, but I think it should be covered by insurance, especially if it is coming in the age group where it is a premature. Whenever it's a premature ovarian failure, I believe the insurances do cover. But when it is the age related, I have a little doubt. I'm not too sure. I'll have to check and let you know. So premature ovarian failure could be due to multiple reasons. The most common is they have undergone a hysterectomy with both the ovaries removed because of some reason. Then these are the women who will be very, very symptomatic, and in them we at least need to give them hormone replacement till such time that they reach the natural age of menopause. So these are the groups which are, they would be, you will be doing a great disservice by not giving them the hormone replacement.
Yeah, but this is a relatively small group.
Yeah.
Compared to the big one, all women should consider hormone replacement treatment, because when you look down the line, why would you do that? You would do that to avoid or mitigate or reduce the possible complications. And the biggest complication is the bone loss. And others are the functional things like the carpal tunnel, like the tendon, trigger finger, and finally there's also the aesthetic thing with the skin and the nails. So if you can reduce this, why not doing this? And for me as a hand surgeon, it just brings me to a better baseline to start from. If I have less symptoms and less advanced symptoms, I can do less invasive treatments. In the end,
that's the most important thing, because modern therapy and innovative technologies is leading us to more safer and less invasive. And it should be more conservative so that it's more acceptable. We always keep the surgical and the invasive methods as the last.
For those cases where all the other less invasive treatments did not succeed, yes.
With that, it reminds me that there is always a golden window of opportunity. Yeah. So we want the women to start it off when you still have that window of opportunity. Why was hormone therapy so much in a negative light? Was because of a study called Women's Health Initiative, and that study came in 2002, and that was the most important thing why, which left a lot of fear and apprehension in the minds of not only the patients but also the healthcare providers. The doctors were scared to prescribe it because the study was a little flawed, and they included women who were beyond 60. So if you start the hormone therapy at the right time, which is, the guidelines, the new guidelines and all, they recommend that within 10 years of menopause, then you avoid all these health-related risks.
You reduce it. You don't avoid it, but you reduce it.
Yeah.
But the problem is that the menopause is now starting at an early age because of the metabolic problems. The more body weight you have, the more hormonal troubles you have. It's not only the female hormones, but it's also the thyroid. But those hormones are playing together. So if I have a thyroid problem and if I have too much weight, I will have a more pronounced or an earlier menopause. Or for the men, it's the adrenopause. We have the same too. We don't talk about it, but we have the same too, and we have the same.
No, testosterone
problems.
is an equally important hormone even in women. And we see that, the deficiency of testosterone also leads to a lot of symptoms, especially lack of desire of having an intimacy, lack of libido, and also the muscle mass, the muscle strength, and the energy. Yeah. So a lot of women, they benefit when, the individual symptoms, it can be individualized and we can give the treatment. And so for the hand also, it can help them. I see a lot of women who also have associated vaginal dryness and recurrent urinary tract infections. So, a lot of doctors and gynecologists are okay with giving local estrogen creams. So, vaginal creams and estrogen creams, they are absolutely like minimal, or you could say nil risks when it comes to hormone therapy. So,
Well, that's the same what we do with the cream in the hand, you know. It helps you a little bit, it helps you to moisturize, but it's it's not treating the root source of the problem, you know. If I can do this with a little bit of hormone replacement and I have all the negative effects mitigated, that's the good thing we should think about, you know.
absolutely.
And that is why a cooperation with you and me is very fruitful for the patient. We can easily incorporate if there is some neurological problems. You know, you said the brain fog. Why not sending this to the neurologist and the neurologist give him some new treatments just to change the mood?
Absolutely.
This is what.
I see a lot of migraines.
Yeah.
Okay. So they are unnecessarily being given a lot of painkillers.
Yes.
So migraines also improve drastically
Yeah.
because of they are especially because of this hormone depletion
Yes.
and the deficiency.
It's the same in for the brain as the pain for the hand. You'd give a little bit of the hormone, you level the lack of the hormone, and you have a lot less of the symptoms which are really reducing your quality of life.
Absolutely.
And that is what we should aim for in longevity, is not to live longer, but the time we live in much better quality of life.
Quality of life is the most important thing for I think each individual, every individual. Here the focus of healthcare is preventive.
Yes.
Okay, preventing long-term illnesses, and we see that if you have a healthy body and a healthy mind, you're disease-free and you enjoy life better. You can have a better performance. So you're performance-oriented, your quality of life, the longevity, and disease prevention. So when you come to a doctor, obviously we are also doing your screening. So a healthcare provider and a collaborator makes sure that you're adequately screened before all these things are given to you. So the very fact that the woman is, going to a doctor, like for example, she comes to me as a gynecologist, I'll do her screening, I'll do her pap smear, I will look at her endometrial lining, I will make sure that her, the blood work is done, the labs are within the acceptable levels, and when she comes for a follow-up and she comes for again a review of her symptoms, we make sure that we give the dose which is appropriate and also enough and not overdosing her. So these are some things which will bring her back to the doctor and also optimize her health care. Uh, Eventually, in the long run, it's going to be beneficial to these ladies. And there is no like a kind of an expiry date, or we could say that the limit to how long you can give.
Yes, I think that's an important point. You should start early on, but there is no limit. It's not that a woman is beyond 65 that you should not give these treatments anymore. You have probably in for us, we treat them differently, and we have more pronounced pathology. So more of these have to have surgery in the end. But again, if you treat them earlier, we can bring this to a later stage and avoid a big number of those surgeries and do a non-surgical treatment with the same effect for the patient.
Yeah. So the bottom line is just to give them a good quality of life, and as long as the benefits are outweighing the risks, it can be given. And it needs to be reviewed, and you need to make sure that the woman comes and understands what are the you could say the side effects or red flag signs, and when should you come back and reconsider and check for the symptoms. So most of them are when they are postmenopausal and when they are on HRT, and if they suddenly have a spotting or a bleeding, then it's a bit discouraging. It's a bit of a kind of they get a little upset, or they would get worried. But we have special guidelines now.
Yeah, and
so
do we, and as we bring them together, I think the benefit for the patient is outweighing any risk of any treatment. And I think it's very nice. And thank you for being there, and thank you for discussing this important topic.
I would like to thank you. It's absolutely a pleasure, and I know how good a service you're doing to women with their hand, and it's one of the very important aspects which is often overlooked. And we as doctors, we need to identify, because the patient education is not much, and if we can identify and we can guide the patient in the right direction, it does a great deal of service, and it does a great deal of benefit to them, because not only in their each age criteria, they have special demands, special needs. So is the need for hormone treatment and hormone replacement. And I'm glad we discussed this in detail and at length. And I hope women who are watching, and they get more aware, they get more encouraged to come and approach us, ask us the right questions, bust the myths, make sure that the misconceptions are removed, and they get it from the right person. Thank
Thank
you.
you so much.